Good evening, everybody, and thank you for joining us again for one of our Kelly Gynecologic Oncology Service, Susan Elberger, MD Gynecologic Cancer Survivorship Program webinar in our series. And tonight we are very excited to embark on a topic that I think is of great interest to many people, cancer survivors, their family, their friends, but I can tell you probably the single greatest question I get asked as an oncologist is the topic of tonight's webinar. And that is nutrition and cancer, and what's fact and what's fiction, and how do we sort out what's fact and fiction. And so the other piece that I'm very excited about tonight is that we have Mary Eve Brown with us, who is a nutritionist here at Johns Hopkins. She has helped us with our prior conferences and retreats and education sessions in all sorts of different forums, and meets with many of our patients. I'm going to let her introduce herself also, but I just have to make a pitch that she is one of those people who is laced through all of our patient care and all of our programming, and who we're very grateful to have be part of our team, but who maybe most people, when they list off team members, she's one of our quieter heroes. She's everywhere at all times, and doesn't necessarily always get the public thanks and praise. So tonight I'm going to take that opportunity to do that, because I think she beyond deserves it, is an incredibly important member of our team. And Dr. Beavis, one of my partners and another GYN oncologist here, who I could equally sing her praises about all of the many wonders of her, but probably most of you know her and know all of those. So I'm going to focus tonight those introductory welcomes and thank yous on Mary Eve. And now I'm going to actually let each person introduce themselves. For those of you who are new to our webinar formats, they are extremely casual. We have everybody introduce themselves, tell us where they're from and a little bit about their background that led them to be with us tonight. Also give us one fun fact, if willing. We like fun facts about something about you that somebody may not know if they only meet you in a professional setting. For instance, woodworking or pottery, or playing English handbells, softball team experiences, anything fun, or you can skip that. And so we'll get started with self-introductions. So Mary Eve, do you want to go first?
Sure. Thank you so much, Dr. Wethington. That was lovely. So I'm Mary Eve Brown. I'm a registered licensed dietitian nutritionist. I'm also board certified in oncology with the Academy of Nutrition and Dietetics. I've been a dietitian for over 30 years. I've been with Hopkins in the outpatient oncology department now for 20 years. And the GY team is so awesome that I get to see all of the ladies and develop individual nutrition care plans for them based on their disease and their treatment. And it's been a wonderful partnership. So a fun fact about me, I grow orchids. And they're my pride and joy. And there are 4 of them are blooming right now. I wish I had them with me, but yeah, I love them. I've been doing them for about 5 years now.
That is fabulous. I didn't know that. My favorite thing about this is I learn great things about everybody when we do the introductions, and I didn't know that. And Dr. Beavis is smiling because she knows that I love plants and I love gardening, and my thumb is a little brown. And so my affection is I'm in process of learning, and that's been my COVID hobby that I took up, is gardening. So I will be coming back to you with not only nutrition questions, but now some orchid questions, because I had one that literally this week dropped its bloom and needs to be redone to rebloom. So
repotted.
Yes, exactly. Yeah, we'll definitely revisit that. Dr. Beavis, do you want to introduce yourself?
Yeah, sure. I'm Anna Beavis. As Dr. Wethington said, I'm one of the GYN oncologists here. I've been here, it's 5.5, 6 years or so, maybe longer, I'm losing count. And then my fun fact, Dr. Wethington already knows, but it's one of her favorite fun facts about me. Like I said, my fun fact is just that I bike to work most days. And her fact that she likes is that I biked to and from my wedding.
Oh.
Very true. It is one of my favorite fun facts about Dr. Beavis. So I'm glad we shared that. So as I sort of said in the introduction, we're sort of here to talk about nutrition. And patients, I think, when they're diagnosed, they get a lot of messages about what they should or shouldn't be eating, and it gets all very complicated. And I would, lots of sort of musts, right? You must do this, you must do that, you must eat this, you must avoid that. And it gets very, I get overwhelmed hearing about all the things that are being said and all the contradictory things. And so what I thought we could start out doing is there are a number, but a small number, a core of common diets that patients ask about. So what I was hoping we could start out doing is kind of talk through each of these core recommended diets or sort of popularized recommended diets that people kind of have to follow, and a little bit about each of them. So things like, why are they popular? What's the potential benefit? Is there science behind the diet? Are there potential harms? Those types of questions. So we'll start with this sort of, what are all these fad diets? What do they mean and how do we interpret them? And we'll kind of go one by one. That's where we're going to start tonight. So probably one of the, well, there are many that get a lot of attention, but let's start with the sugar-free. We'll start with that. Dr. Beavis is smiling because she knows this is one I talk about a lot. So the sugar-free diet, I can't have any sugar, I have cancer. So is there, Dr. Beavis, is there science behind that statement? I can't eat sugar, I have cancer. My cancer is going to explode if I eat sugar.
I think both Mary Eve and I probably have a lot of responses to this because I think it's the number one question about nutrition that I get asked. And I think that has a lot to do with, I think, some misunderstanding about how our body really takes in food and what it does with it. So the short answer to your question is that no, there's no science to say that lots of sugar is going to make your cancer grow any faster, or not eating sugar will make your cancer grow slower. But I think that where it comes from is that every cell in your body runs on sugar. Everything you eat, your body can turn into sugar. So if you ate no sugar, your body would still be able to take your fat and break it down and make it into sugar. And so if you try and not eat sugar, your body will still make that sugar because it needs it for all of its cells. You cannot live without it. And so while avoiding lots of, processed foods and simple sugars is good for your health, you're not going to starve your cancer, which I think is a lot of what you read about on websites. And I always feel badly as I have a sweet tooth. And if I suddenly couldn't eat any cookies or cakes or whatever as a treat, when I was going through something like that, like cancer, it would definitely negatively impact me. So I feel like everything in moderation, but there's no way that cutting all the sugar out is going to stop the cancer from growing. But eating excess sugar, I can't endorse either.
Yeah, if you look at the body's much more complex than that, right? This is kind of how I think about it is if you're eating a healthy diet, an occasional something of sweet is not a risk. Now, if you're just eating all sweet things, that is a risk because then you're missing out on other nutrition. So I tell people, 80-20, 80% of the time I eat a healthy diet, 20% of the time I can have a treat if I want to. I do caution people about drinking sugar. So, because that is a really a negative calorie source that people don't register in their brain. I got on the elevator, this was before the pandemic, and there was 3 generations. It was a grandmother, a mother, and a daughter. They were all overweight, and they all had huge coffee drinks, frozen coffee drinks in their hands. And the little girl, who might have been about 10, had a Mountain Dew. And in my head, I'm screaming, don't do that, don't do that. Because when you drink something that has a lot of sugar in it, you don't get the same hunger triggers to stop eating than if you ate a solid food. And, obesity is a huge risk for cancer. And people, I think, are not realizing that, I'm drinking 600 calories and it's all sugar. So that is one area I do say that if you want to look at that area, I think it's a good idea not to do that. But just as Dr. Beavis said, eliminating sugar is not going to change your disease status anyway. You're muted.
Oh, I've done a lot of these and I haven't done that yet. You mentioned something about how Oh, and an important point, that obesity is a risk factor for cancer. And we certainly have people who are listening who don't have cancer, who are related to somebody who does, and that's how they kind of ended up listening to us. But most of our listeners have had a cancer. So when you talk to someone about weight loss and cancer, how do you frame that at different stages? Sort of, how do you introduce that topic in the new?
Yeah, because we know that weight loss during cancer treatment can be a negative, right? It's weight loss in the setting of illness instead of weight loss in the setting of health. I don't encourage people or ladies to lose weight during their cancer journey, but definitely there's really good science behind after treatment and recovery, weight loss is a positive. Just the other day, I was looking at something for something else, but and this comes from breast cancer, which is not the same as GYN cancer, but in the breast cancer population, they found that if overweight ladies lost less than 6% during their treatment, it actually was a positive. I don't like to anecdotal go from one disease to another disease, but I think if it's in the setting of I'm eating well, I'm being physically active, I'm doing okay, I think moderate weight loss is okay. The significant thing was 6%. When ladies lost more than 6% during their treatment, it actually interfered with their treatment. They had more treatment delays, they had more problems with tolerating their treatment. So it's a very small percentage, but I think it's worth a discussion with the dietitian and with the physician. Is this something that I should be doing or I shouldn't be doing?
I think that's a really good point because, often when someone gets the diagnosis of cancer, they immediately want to do whatever they can to help treat it and also help prevent it from coming back. And so there are lots of these fad diets, right? We've talked about one of them. But if you go on a really highly restrictive diet and have rapid weight loss at the beginning of treatment, that can definitely have a negative impact.
And weight is not always an indicator of nutritional status.
Mm-hmm.
People, if you look at them, they look overnourished or overweight, but really when you fine tune it, they're actually malnourished because they've lost so much weight prior to treatment and then they lose more weight with treatment. So it's really a discussion about what's good weight loss and what's not good weight loss.
Dr. Beavis, what about endometrial cancer and weight? Because I think for us in GYN, I know in breast there's quite a bit of information about this, but for us in GYN, I think we get a lot of questions about endometrial cancer and weight. So how do you advise your patients who have an endometrial cancer about weight and how to incorporate that into their treatment plan?
So endometrial cancer is one of my areas, both of clinical and of research interest. And for people who don't know, the endometrium is just the lining of the uterus. So endometrial cancer is cancer of the uterus, but specifically the lining. And we know that this cancer is, of all the cancers in the world, is the most sensitive to obesity. And in essence, that's because obese people have extra fat cells that make estrogen, and the estrogen drives the cancer to grow. And so for my patients who are diagnosed with endometrial cancer, oftentimes they are overweight or obese. And I think it's a really delicate conversation that you have to have because I think oftentimes obesity is in society seen as someone's fault, and it really is not. I think that's it's something that's changeable, but it's not anyone's fault. They didn't mean to be overweight or obese, right? It's this complex interaction of the world that we live in, the fact that we sit in chairs and drive in cars, and the diets that we're exposed to, etc. So I think that's a really important point. And then secondarily, when someone's done with treatment, we know that they were more likely to get that cancer because they were overweight or obese. And if they don't then lose any weight or change anything as far as if they have diabetes, hypertension, getting control of those things, then they're also more likely to die, not necessarily of the cancer, but of the consequences of the obesity. So I think it's a really challenging discussion to have with someone to say, you have this cancer, it was probably because you're obese and we need to fix that. So it's usually something I have in stages. But once you're done with treatment and kind of recovered, it's time to have a conversation about addressing that excess weight and the fact that most endometrial cancer is curable. But if you're going to die from the obesity that caused the endometrial cancer, let's use this as a moment to say, okay, let's do something, let's change something. This is like a fork in the road kind of situation.
I think that's important. And I think that doing something, to Mary Eve's point, comes after the treatment, which I think is important. It's an aha moment that we then address sort of after treatment. So I think that's I think you sort of both summed it up. We're starting to get questions, which we knew would happen a little bit. And so the next diet I want to talk about is not the diet that I explicitly had on our list, but I'm sure one that you both got asked about. And Mary Eve, I know this is something you help all our patients with, which is, what should my chemo diet be? So the way the person phrased the question is, when I was going through chemo for ovarian cancer, in this particular person's case, but I think anybody on chemo it would apply to, the advice I got was to eat whatever I could keep down. You want to stay hydrated, you want to get protein. These are the two key elements the person was told. And as a result, that's what the person did. And in this particular case, they point out, which to me is super common, all this person could tolerate was baked potatoes with butter and butter pecan ice cream. And those are the things that the person tolerated. So when people are specifically on chemo, is there a chemo diet that they should follow? And how do you help people who are specifically on chemo, which we know can cause nausea and all sorts of GI distress?
It's, and you guys know this, we put a lot of people through the same kind of treatment, and they all kind of have different experiences because everybody is unique. And traditionally chemotherapy affects the gut lining because those are the cells that turn over the quickest. So from the mouth all the way through. Yeah. Hydration, yes, key. Protein, yes, key. But then there's some other things that you can do to kind of help with some of the side effects of the treatment. So eating small, frequent can sometimes help with if you're having early satiety, which just means I'm filling up quickly, or I don't have an appetite, or my tummy is queasy. Doing things that don't have a strong odor to them, things that are at room temperature or cold. That's the baked potato and the ice cream probably, because they don't have a strong odor to them, but there's not much protein there. So we need to figure out the protein thing.
Yeah.
This sounds really weird, but not eating is not a plan. And sometimes people think, well, if I just don't eat, I'll feel better and it'll be okay. And then they get the next treatment and it knocks them down further, and the next one further. So I always say, not eating is not the plan. Is that figure out kind of small, frequent meals, eating and drinking separately. Because if you're drinking, sometimes you fill up and then you don't eat as much of the solid food. Doing things that are easy to digest, that are bland, that don't have a strong odor to them. That's really kind of the foods that are going to sit the best with most treatment side effects.
Do you have any tips you throw in, Dr. Beavis?
I think a few. So I think number one, it's definitely something your doctor wants to know about, because there are, right? I mean, Mary Eve's going to know more with her 30 years of experience and have more, tricks up her sleeve than necessarily Dr. Wethington or I would, but we all have experiences. And so I think a lot of times people will take on these chemo side effects and not really say anything. And there's actually, the American Cancer Society has this wonderful, massive list of things that you can try. One of the things is just drinking it through a straw, right? So let's say you're doing an Ensure supplement, which is a liquid. So your body's not going to register it potentially as full as it would a solid food. So you kind of use that to your advantage. And then you drink through a straw, so you won't be able to taste as much. And I don't know if there's a study on this, but I definitely find if I'm drinking through a straw, I drink more than I would have if I weren't. And then making sure, so figuring out, right, is it dry mouth? Is it nausea? Is it lack of appetite? Because those three different things, or change in taste, right? Those things all may contribute to not wanting to eat food, and all four of those have a different potential treatment. But I would say to someone who can only eat ice cream, then take a protein powder, add it, put it in a blender, and then drink that through a straw.
And it's funny because I find people report nausea is subjective. What are person think is nausea, another person thinks is reflux, another person thinks that I'm just really full and bloated. So it's kind of fine tuning, what does that mean for you? You know what I mean? And then coming up with a plan that kind of addresses what that means to them. The other thing you said that was really smart is people have this notion in their mind, oh, I'm in chemotherapy, I'm supposed to be sick.
Right.
But that's not true. It's not true anymore. We have so many good support medications. It's just finding the right amount of what you need. And it might be a tweaking. The first time I go through it, I'm sick on day 4. You know what I mean? So it's just kind of talking with your provider about how you were feeling in the days after, and then tweaking it with changing medications or deleting medications or adding different medications. Yeah.
Now, are you supposed to avoid your favorite food when you're on chemo?
So you can get this thing called food aversions, which means that I ate this, then I threw it up and I never want to see it ever again. So that is a true thing. There's also anticipatory nausea, which means that the last time that happened, I got really sick. And so I have that in my memory now. And so when that happens again, I'm going to get really sick. So sometimes we'll tell people, if you're having a bad day, don't eat your favorite thing. Eat those on a good day.
I'm going to move on to another diet, but I want to ask one other question, which sort of overlaps with all these GI topics that we're talking about right now in food. And that is about the gut microbiome. There's like a lot of attention that's been drawn to this. And so and there are different ways to affect our gut microbiome in different ways when we're on chemo. Do you recommend to people as a result of that any sort of probiotics or increased yogurt or any sort of adjustments in order to address gut microbiome, or do you sort of leave that in a separate category?
Dr. Beavis, do you want to answer that first, or do you want me to go?
I will give you my answer. I can't tell you that it's based on a lot of science. I'm going to give you that caveat. In general, I don't think taking a probiotic is ever really a bad idea. I think getting it from a source like a yogurt that has extra probiotics like Activia has been, has gone through the USDA or the FDA, the USDA, I think, for foods. Unlike supplements and some of your probiotics, which if they're over the counter and considered a supplement, they won't be regulated in any way. So I am probiotic, but I tend to encourage them from sources that I think have been vetted.
Real food sources instead of supplements.
Yeah, or I think there's a couple, and I don't have the name of them off the top of my head, but there's one or two that I know are kind of more stringent about their quality.
And there's a couple of strains that have more science behind them than others. So Bifidobacterium and Lactobacilli IgG have science behind them. I've done some research in looking at this because I get asked this a lot.
Yeah.
So, what I've kind of learned about is everybody's microbiome is unique to them. People who live in the same households can have similar strains. So there are prebiotics and probiotics. So prebiotics are what the probiotics live on, and that is plant food. That's what they live on. Most people through a varied diet don't need to take probiotics because you're eating the things that the things have to live on. But if you have a situation where I was on an antibiotic and that decreased my microbiome, if I had a cancer treatment that my gut lining kind of was assaulted, which is kind of common, and I'm not able to eat the foods that the bacteria need to live on, should I be taking a probiotic? I like what Dr. Beavis said. So could it be kombucha? Can it be kefir? Can it be yogurt? I think the body's response to those is much more so than taking it in a pill form. And the other thing is, if you are neutropenic, which is a low immune system, we do not recommend taking probiotics at all because they actually cause more harm than good. So I'm a real food person. I would want to get them through my food instead of taking it as a supplement, unless I've had an antibiotic and my microbiome is really low. It is sometimes recommended to take a probiotic. Or if you have C. diff, then it's recommended to take a probiotic. probiotic.
One other question about the sugar diet, which somebody asked, which I think is a good question. You know, the person says, I'm having a hard time getting off sugar. I eat sugar. I'm having a hard time getting off. Any suggestions for the person asked it specifically about sugar, but I'm going to ask it more generally. If somebody wants to make diet changes, do you have any tips or tricks to how to successfully make diet changes? I think sugar is a hard one because it is addictive. And that's where the question comes from, I think, is that addictive property of sugar and changing that habit.
So I always approach kind of dietary changes in a behavior modification way. So let's say I'm doing something every single day. I'm going to make this up. Every afternoon I eat a candy bar. So now maybe I only do it 5 out of 7 days. And then I do it 4 out of 7 days. And then I do it 3, I kind of wheedle myself down so that I'm not doing it every single day. I think that's an easier than cold turkey. I mean, cold turkey can work for some people, but I find that diet modification works for the majority of people. And then maybe switching it to something that's a little bit healthier for me. Could it be a fruit something instead of like a sugar something, because fruit is sweet. So, looking at the frequency of it and then maybe switching it to something that's a little bit healthier for me would be what I would suggest. That's
an interesting point. You made a distinction between fruit and other sweets. Is there a difference between eating a cup of grapes and eating a cup of ice cream? It's a bad choice because I think grapes are the highest glycemic index fruit. So is there a difference between eating a cup of apple slices and a cup of ice cream?
It's interesting you picked ice cream and fruit. So I was talking like Snickers. So when we eat fruit, we get other phytonutrients, which are cancer fighters. It comes with fiber, comes with vitamins. So whereas fruit is sweet, we don't count that as added sugar. So when you're talking about the sugar diet, you're talking about added sugar, not fruit.
Okay.
And we need 2 to 3 servings of fruit every day.
Okay.
And I think just to echo on what Mary Eve said, so as previously stated, I have a sweet tooth and it's definitely a problem. And it's definitely something I will admit that kind of waxes and wanes as far as how much of a problem it is. So for me, I know that if I went from like 7 days to 5 days, I would just cheat and end up at 7 days. And so for me, what has worked is saying, let's say I eat a candy bar every day, for example. And I know that basically this piece of food is not really adding any nutrition. It's just adding some calories, but is otherwise not very good for me. Then I will cut that in half, whatever it is, and literally throw the other half out because it is better in the trash than in my body. And then eat less and then kind of reduce it that way. And then find something else to replace it with. But for me, I need a sweet every day. It's just, it's just, I wish that weren't the case. But
is it ever dark chocolate?
I prefer milk, but yes, it is sometimes dark chocolate. And I love like a mango, right? Like I know that's, it's got quite a bit of sugar, but also has fiber and a lot of different nutrients. So it's definitely, there are other things, but I feel anyone else out there who's got a sweet tooth and is struggling with it, I feel you.
It's true. I'm the same. I could eat a chocolate brownie every single night. No question about it. No question about it for sure. Now you asked about dark chocolate. Mary, you said, is it dark chocolate?
It has antioxidants in it.
Yeah.
And so that can actually be a good thing. It's 1 ounce a day though. It's not like eating a whole
bar. Yeah. 1 ounce would be pretty nice and satisfying. Now let's move on and talk about a different diet, the keto diet, which it gets a ton of attention. What is the keto diet? What's the concept behind it?
So the ketogenic diet has been around for almost 100 years, and it's been at Hopkins for 80 years in the neurology section. So it can help with people who have uncontrolled seizures, who have failed multiple tries of medications. So we actually have an adult ketogenic clinic at the hospital. They've been studying these people for long periods of time, and they do very well. I think what has happened now is that this goes back to this sugar thing. So malignant cells cannot use ketones for energy. They have to have a glucose source. So I think people got onto this like, well, great, if I get into ketosis, my cells will all die, and then I'll get rid of my cancer. It's not been proven yet. And there are side effects to the ketogenic diet that can be very difficult to navigate with the treatment. So a traditional ketogenic diet is 80% of your calories come from fat. You only do less than 20 grams of carbohydrate a day, and then the remaining calories come from protein. So it's not a high protein diet, it's a high fat diet. And I have lots of people who ask me about it, and you really have to look at the whole picture to see if this is something that somebody wants to do or not. We know it's safe from a medical standpoint because we have this population of people who have done it a long period of time, but it's not come over to the oncology arena. It's still being investigated. And actually there was a multi-center trial that was done. It closed in September of 19, I think. It's with a particular type of brain tumor called a glioblastoma. So they're following these people who have been through treatment 6 months out, and then they put them on a ketogenic diet to follow them to see if there's any kind of benefit that can come from this diet. That's the only area right now that's a possibility. So it's not in the GYN cancer group. It's not in any other cancer group, but brain tumors, because brain tumors are very different than other types of tumor. The side effects of the ketogenic diet can be constipation, can be nausea, can be anorexia, can be, weight loss, fatigue, and fog. And some of those things happen with our treatment. So I always warn people that, okay, if you're already having all of this, now you want to do this, that might not be the best plan for you. And then you're kind of eliminating all those cancer fighters, right? All those phytonutrients that are in plant tissue, plant products that help. We do know that fight against cancer. So that's kind of my theory about it in a nutshell.
Yeah, I think I would add that it's been around a long time. But I also think, anyone who's going to do some kind of drastic change in their diet, it especially initially should be monitored somewhat by your doctor, and probably not your oncologist necessarily. And also, if you're starting treatment, it's not the time to use this diet. Oftentimes, the ketogenic diet originally was lots of fat. Now there's a high protein version of the ketogenic diet where more of your calories are from protein. And often when people start these diets, they have rapid weight loss initially, and that wouldn't be safe if you were just starting treatment. I imagine that's why the glioblastoma patients need to be 6 months out, right? It needs to be a safe time to change your diet. So I definitely think, Atkins got a lot of attention, and we do know cutting out carbs can definitely help people lose weight. There's no question that that's been shown. It's just not necessarily something I would recommend for someone who's undergoing treatment, although it could be something to consider with a nutritionist or an internal medicine doctor kind of down the line.
And particularly for us ladies, we have to worry about our bone health. And that can be a big concern with the ketogenic diet because you're not getting the nutrients that you need and the amount that you need. So that would be supplementation that you would need to talk to, with a doctor.
That's a very good point. That's a good point. So let's move on to another diet. In some ways, maybe the opposite of the keto diet, maybe not, but a plant-based diet. Somebody asked about this, and I have it on my list to ask about, so we'll move to it next. I certainly get quite a few patients who come in and have given up all meat, and sort of that's their approach. Somebody in their family told them the meat causes cancer. I think sometimes maybe that, especially sandwich meats, people focus on. I think that derives from some of the GI cancer literature specifically. But what's the, why would somebody say, okay, I want to do a plant-only based diet? What's the kind of idea behind that? Dr. Beavis, do you want to go first?
Sure, yeah. So a plant-based diet, the term plant-based diet, I think is pretty broad. So the Mediterranean diet, which I don't remember when that was first proposed, but it was a long time ago. That's kind of a version of a plant-based diet that allows a little bit more flexibility, but your classic plant-based diet is going to be fruits, veggies, nuts, seeds, oils, legumes, beans, and then really no meat, no fish. And the Mediterranean diet allows for a little bit of fish, a little bit of poultry, meaning those like chicken, right, which is a lean protein, maybe some cheese and yogurt, which gets you a little bit of dairy. So I think, I mean, overall, the plant-based diet is, so long as you are able to get all of your nutrients from it, and you certainly should be able to with some dairy. You know, we didn't talk about vegan diets yet. The one thing, and I think Mary Eve can probably speak to this as well, but with a vegan diet, we do worry about vitamin B12 not being absorbed properly. It's just not possible with a vegan diet. But with the plant-based diet, I mean, if you make 50% of all of your meals veggies and fruits with using those other higher calorie things like nuts, seeds, oils, legumes, those things more on the side, like 25% of your meals, then you can actually make a pretty healthy meal plan, I think, from a plant-based diet. So to make sure you're taking in enough protein.
Yeah, the plant-based diet actually has a lot of science behind it. And a plant-based diet doesn't mean that you don't do animal. It just means, like you said, the majority of what I do is coming from the planet and less of what I'm doing is coming from animal. Another word for it is called a prevention diet. So really, a plant-based diet can prevent all diseases. It's the root of all, like heart disease, diabetes, obesity, hypertension. It all goes back to the same root, which is kind of nice because once I'm a cancer survivor, I still have to worry about all these other things that could happen to me. I could get diabetes, I could get high blood pressure, I could get, other things. So if it's all one diet in one step, woo, that's a win-win. I only have to do one thing. So I highly recommend a plant-based diet to people. Maybe not so much in treatment because foods can be difficult sometimes to digest when I'm going through the treatment, but definitely a lifelong thing of a plant-based diet, I think is actually has the most science behind it at this point. I think, so, and this is what I tell people, is that you need vegetables, half cooked, half raw. They need to be a variety of color. So, kale got this gold star at one point in our lives that everybody had to eat kale. I'm like, well, then what about things that are orange and red and purple and white? You need all the different colors because each color gives you a different cancer fighter. And then Dr. Beavis said a great thing. So yeah, you want to look to proteins, but in plant form. So that's lentils and beans and nuts and seeds. Those are all things that provide plant-based proteins, and they also provide vitamins and minerals. You do want some dairy in your diet because, again, it's cancer preventative, more for GI, but still, and we have to worry about our bones. So you need 2 to 3 servings of a non-fat dairy every day. That could be the yogurt or the kefir, cottage cheese. I tell people, try to work in a couple of days a week where you're vegetarian that day. That reduces the amount of animal that you're doing. The only other thing with a plant-based diet that is recommended is having a high-fat fish twice a week. Provide omega-3s, which are anti-inflammatory. And so salmon or tuna, herring, sardines, I don't eat those, but those are also high in fat. But that would be the one animal part that I would try to get in more would be the fattier fishes. The other thing about a plant-based diet, it tends to be high nutrient value and high volume, but lower in calorie. So it can help us to maintain a healthier body weight because we're eating these foods that are volume, right? So if I'm eating a big salad and I've got beans and seeds, I'm going to feel full, but the calories are lower because it's higher in fiber. So I get satiety or I get fullness, but I'm not eating tons of calories at the same time. The other thing about a plant-based diet, and I don't think people realize this, it takes time to eat it, right? So if I'm eating something that's Cheetos, I could eat a whole ton of Cheetos, but I'm sitting down to eat an apple, it's going to take me a while. Or I'm eating a salad, it's going to take me a while. So it physically slows you down. So you tend to get fuller quicker and eating less and less calories.
So then in the context of chemo, it's important, right? That is a very healthy diet. And I agree with Mary, even it has a lot of data to suggest it's a great preventive diet. But if you're getting full quickly and you're losing weight on chemo, then trying to stick to a plant-based diet is probably not the way to go.
No. The other thing is, do you have good days and bad days? So do I have days around treatment where I'm just really having a hard time, I'm going to eat da-da. But on my off week, when I'm feeling pretty good, do I do a plant-based diet? That might be a possibility too.
Yeah. And they've made it, I mean, I feel like our food services have given us some tricks. Like now there's the pastas that are actually not pure wheat, but have integrated, and our protein pastas. Dr. Beavis is laughing because this is my favorite thing to tell people about. I tell everybody who's starting chemo, like, buy yourself the protein pasta, because I feel like it's easy to tolerate, but it has some of these plant-based, nutrients and sort of strengths, snuck in there. So it's easier to tolerate. Yeah, so I definitely agree. We're getting actually some more good questions. So I want to keep drawing on these. And one of them in the plant arena, because I want to stick in the plant arena. Somebody asked about tamoxifen. And so I'm going to ask their question, and then I'm going to segue into another plant question related to this. But they asked specifically, am I supposed to be on a special diet because I'm on tamoxifen? So I'd like to answer that person's question, but I also want to broaden it. And are there any chemo regimens where we tell people that they can or cannot eat anything? So specific to tamoxifen, and then in general, are there any you cannot eat this when you're on this chemo regimen alerts that we should take a PSA moment to point out to people, since this question came up?
So for tamoxifen, I know one thing that we tend to monitor, can worry about, can be an elevation in cholesterol, something that we monitor sometimes when people are on it, although I haven't seen a huge amount of changes, especially in the patients I've checked it in. However, I don't think I would say anything other than to avoid high fats, high cholesterol foods and eat a balanced diet, but I don't have any specific restrictions other than that.
Yeah. Mary,
are they worried about soy?
So that's actually where I was going to segue. So the person actually doesn't say, they just specifically say, is there a specific diet I need to follow on tamoxifen? And in my mind, where I was going to segue when I said I'm going to lead to something else, and this is, well, this raises a question, because I've also gotten this. Can I have soy? I had an endometrial cancer, and can I have soy, or, any cancer? Do I need to avoid soy products? So how do we address that? Because it's an interesting question.
Yeah, so the most recent information about soy and hormone tumors. So the American Institute for Cancer Research, AICR.org, is a fantastic website that provides the latest compiled data about diet and cancer. And their position is 2 to 3 servings a day of soy is deemed safe. So the phytoestrogens that are in soy, at one point we thought that might be an estrogen in the body. It's not. It's handled very differently, and we now actually think that it's a cancer fighter. Studies are really interesting that they tend to have more soy in their diet early, and they found that when girls had 2 to 3 servings of soy pre-pubescent, had less breast cancer than women who didn't. Now that was in Asia, but they think it's actually protective. So I recommend, 2 to 3 servings of soy is safe. I'd not recommend soy supplements. Those are not safe.
Oh, you're on mute.
You're mute.
The second time.
Second time in one night. I haven't done it in like 15 of these, and now twice. There's a siren going off, so I was trying to be more polite, so I apologize. Usually I don't mute it. So somebody asked, in the supplement realm, are there any supplements that someone must or should or really should, whatever word you want to put in there to describe, come off of or stop taking while they're on chemo because they interfere. And I'm talking common things like, can I keep taking my calcium? Can I keep taking my vitamin B complex? What about antioxidants? Do they interfere in my chemo? Somebody mentioned turmeric specifically in the question. But are there supplements that Mary, when you do the nutrition counseling, if you see them on the list where you say, please stop taking this, like the soy supplements, for instance?
Yeah, no soy supplements. And so what is not, so minerals are antioxidants, right? They protect they protect cells from damage.
Yeah.
We don't know if taking antioxidants would also protect tumor cell from damage. So if I see somebody's taking a lot of antioxidants in pill form, I ask them not to. And it's not in food source. So if I'm eating a bunch of fruits and vegetables, that's fine. If I'm taking a supplement that's a huge amount, I caution people from that because I don't know if that's safe or not. I'd hate for you to go through all this treatment and render it less effective than what it could be.
Mm-hmm.
We do know a multivitamin that provides 100% of the RDA is safe. That's science and evidence-based, but taking individual supplements are not. Turmeric is really interesting because turmeric is highly an antioxidant. Would not take it in a supplement during the treatment. And I don't know if I would use it daily in cooking because again, it's just such a high antioxidant. I worry about people taking multiple different supplements because even though it's natural, they can have side effects to them. So, all of a sudden, if your platelets start dropping, we start looking at a whole bunch of stuff and it comes to be that they were taking 5 different supplements that all caused, blood clot problems. So it is worth a discussion to go through each one, but antioxidants is the one that I normally tell people do not take.
Yeah.
And I would say with supplements, as we talked about earlier, they're really not regulated. And so sometimes the supplement itself is fine, but the carrier, whatever makes it into a pill, has a certain side effect. And so oftentimes we'll see changes in liver enzymes. And when that happens and I have no reason why it's happened, the first thing I do is have the patient stop all the supplements. Because even if it's the exact same supplement they've taken for 10 years, if that company decided to get, source one of the ingredients from a new company, it is not regulated. And so there can be, you can definitely get side effects, and it's, you don't want to delay your chemotherapy because you're trying to figure out where this elevated liver enzyme came from.
Yeah, and if you're going to take a multivitamin or vitamin D or calcium, you want USP on the label. So that is an independent testing that guarantees that the product is what it is and that it dissolves and disperses in a period of time that it's absorbed. And it'll be right on the label, it's USP.
That's a good trick. We did a segment back in December. We called it the other medicines. And we talked about supplements that's a whole hour of talking about various different supplements. And so I know we could keep talking about this for an hour. And for those who want more info, I'm going to advertise and say that it was actually a very good session. And so if you look on our YouTube page, you can pull that up and it goes through a lot about different supplements and mushrooms and other things that I think come up a lot. And since we're limited on time, I'm going to move us along because there are a few other diet and nutrition, not diet. I don't like that word, so I shouldn't have used it. There are a few other nutrition things I want to talk about. And one is not a nutrition, but I think it's lumped in and asked. Alcohol. Is alcohol going to make my cancer come back? If I have a glass of wine at night, I know I'm going to start by prefacing by saying we're not talking about during treatment. So I think everybody agrees you drinking during treatment is not a good idea, and please discuss with your doctor. So we're talking post-treatment. I haven't had a glass of wine in 18 weeks while I was on my carbotaxol. Is alcohol, this is one of the questions that count. Is alcohol okay to have occasionally, to have every night? What's the relationship between alcohol and cancer?
So definitely don't have excessive alcohol, but a serving a night, which is a glass of wine for women, is considered safe. And the American Cancer Society actually endorses 1 glass of wine per night. But excessive alcohol can lead to liver failure and liver cancer. So there is a connection between that, but that's in excess of that kind of daily. And Now, one a day does not mean 7 glasses on Sunday. That will have a very different effect on your body, right? That binge drinking is associated with liver failure. So you definitely want it in moderation, and a glass of wine a day is fine, especially if you're celebrating being finally done with treatment.
That's what I say too. Yeah, especially at the end there. So one of the diets we haven't talked about yet is the alkaline diet. And lots of people ask about that. So what's the theory behind why that gets advocated?
I can speak to that. So the alkaline diet, so there's your pH is your kind of your acid base balance in your body. And when you have a lot of acid, your pH goes down. And when you have a lot of base, you have an alkaline environment, and that goes up. And so at some point, the environment around cancer, the pH was measured, and it was found to be acidic, which is likely because the cancer makes it acidic and not because it's growing, right? It's the chicken before the egg kind of thing. We know that cancer makes an acidic environment, but at some point, this diet came kind of into popularity because there was this idea that if you ate a bunch of foods that would make you more alkaline, more basic, and less acidic, then you could maybe stop the cancer from growing. Now, unfortunately, while this diet, there's certain foods you can go and find which are more acidic, which are neutral, which are alkaline. It will potentially change the pH of your urine, but it will not change the pH of your bloodstream and your cells and where your cancer is growing and where your normal cells are growing. And that's actually an excellent thing, because if you could put yourself into acidosis or alkalosis, you would be in the ICU. And so it is excellent that you can't do that with food.
Dead. Yeah. So when you really look at the diet, there's different levels of the diet. If I have somebody who's really, really wanting to do it, I say, well, let's look at it and let's do it safely. The part of it can be low protein, because all of the proteins are acidic. So it's, high in fruits and vegetables, and which is what we're also, talking about. But if you're trying to do it to change your pH, your body will not let you do that, because either end, as Dr. Beavis was saying, of 7.2 to 3 is death. So your body's not going to want to do that. It's going to change something, the respiration or your kidney function, or it's going to change something to get you back to where you need to be. So it can work for some people, but the reason they're doing it is not the right reason.
Yeah, and I think there's some, I was talking to Dr. Wethington about this earlier, the alkaline foods can include fruits, nuts, legumes, and vegetables, which we had in our plant-based Mediterranean diet as good things, and they are still good things. And the restricting processed junk foods, also a good thing. But you can't get all of your nutrients from those things. And so excluding the more, what are considered acidic foods, right? Like the dairy and eggs,
Right.
the egg yolk, I think specifically, and grains. I mean, you're not going to be able to get all of your nutrients that way, and it won't be a balanced diet.
Yeah. What about the anti-inflammatory diet? There's a lot of attention around inflammation in our body being a negative thing, and therefore can we balance it with an anti-inflammatory diet? And does the food we eat create inflammation in our body? So what's sort of is there science behind that? And what is that? What does that diet consist of?
So, I mean, a certain amount of inflammation in the body is actually a good thing. It's when it gets out of balance that can be wrong. But again, if you go back to this plant-based diet, it's rich in all things that are anti-inflammatory. So vitamins and minerals and omega-3s. So these are something that we can sometimes struggle to get into our diet. In fatty fishes and seeds and those kinds of things, avocados. So it all goes back to that same diet.
It's the same kind of diet.
Yeah, it's the plant-based diet. You're going to be doing all of those things in one diet.
Got it. Okay.
Yeah, and it's, highly processed, super greasy, super sweet, sugary foods. All of those would be avoided on an anti-inflammatory diet. So it's, yeah, it's like Mary Eve kind of says that it is very similar. And I think that really the plant-based Mediterranean diet gets you anti-inflammation. It's all of those cancer fighters in your plants and whole grains.
Now, we mentioned chemo, which is one of our treatment modalities, but we didn't mention radiation.
Mm-hmm.
I think many of our patients get radiation, and I think there are a lot of gastrointestinal issues that arise during radiation. How do you, when someone's starting radiation, Mary, how do you frame the radiation experience and nutrition and diet when you're meeting with folks?
So this is how I say it, is that, everything in your cavity is touching everything else. They're all snuggled up next to each other. And so, we're very targeted in the radiation field, but bowel can get in the way. Oh my gosh.
Can you still hear us, Mary?
Wow, I don't know what happened. The Kona Iceman went by and he shut off my computer, I think.
Oh, well, we still hear you, actually.
And see you.
Okay, so I was saying, everything is snuggled up right next to each other and everything is kind of in there, and we're very targeted with the radiation, but bowel can get in the way. And if bowel gets in the way, it can get inflamed, or it's called enteritis. That can cause abdominal pain, and the main thing is diarrhea.
Mm-hmm.
And it may not happen right away, so the radiation is building on itself. So, the first week or so, I'm doing okay. My third week, I'm having terrible diarrhea. So I put everybody on a diarrhea diet, which takes out things that are hard to digest. So, things that have a lot of fiber in them make diarrhea worse, things that have a lot of fat in them, a lot of sugar in them, a lot of spice to them, extremes of temperatures, hot and cold. So it is a particular diet if you're having pelvic radiation. And it's very important, because if you're having diarrhea and you're also getting chemotherapy that may be nephrotoxic or hard on your kidneys, you can actually end up with a kidney injury.
Okay. Do you have any other tips you share? I think for me, I feel like I actually, and this is a deficiency in myself, I'll admit, I don't always address this at the beginning, but I tend to see people after their third chemo infusion or sort of at the end, and then follow them long term. And the radiation can certainly cause GI toxicities long term. So I wonder, Beavis, I feel like maybe we see people later on in the process when they're having GI symptoms. And so what sort of things do you recommend to folks when they're experiencing? I sort of notice more than just diarrhea, alternating constipation and diarrhea. So people get both and it goes back and forth.
Yeah, so you can have like chronic enteritis, like the bowel never ever repaired itself.
Yeah.
One thing I would keep on my radar, and I've seen this a couple of times. So what happens is that because this bowel is not normal bowel, we were talking about the microbiome, those bacteria that live, they can migrate up into the small bowel of unhealthy guts. And you get this thing called SIBO, which is small intestinal bacterial overgrowth. So if I see somebody who's had radiation in the past to their pelvis, never really recovered from a gut standpoint, it's a breath test. Do you have SIBO? And sometimes it does happen. And then we have to put them on an antibiotic to kind of rework their gut. But that is something I think we should put maybe on our radar, and these people that they're just not recovering. Yeah.
That's interesting. That's a good tip. I feel like this is the most common thing I take care of in terms of radiation, patients who've had radiation, is the GI issues.
They may have chronic enteritis.
Yeah. I think many of them do.
Yeah, I've had a couple of patients with SIBO that's been diagnosed, not necessarily post-radiation, but the treatment is very effective. Like very, often it's weeks to months to years of these GI issues that have never been explained. And I think, Marie, you bring up a good point, I think, for both Dr. Wethington and I, in that obviously if someone's had radiation before, we could say, oh, this is just an effective radiation, kind of like when the patient says, oh, well, I'm nauseous all the time because I'm on chemo and I shouldn't expect it to be any better. I think oftentimes there are things happening in other specialties that we, like SIBO, I can tell you was not something I learned about in medical school. I think that it's definitely become much more of a recognized diagnosis recently. And so sometimes even if we think the situation, the symptom is due to chemo, due to radiation, or due to the surgery we did, sometimes just referring to like a gastroenterologist or a specialist in that can be a good way to get a second opinion and someone to look at it from another angle, as opposed to our chemo cancer lens we're always looking at everything through.
I think that's very, very true. I think there's a lot to be added. So I promise that we always stop on time, which I rarely do. I basically get right to the minute, and I'm getting my reminders that my time is up, and I look at the clock and I see that it says 8. So I'm gonna draw us to a close. Thank you both very much. I could keep going. I actually have more questions here. I wrote down questions while we were going, but I will get the hook around my neck shortly if I don't bring us to an end. And for those of you who are listening, I just want to let you know about our next webinar, which will be on May 3rd, which is a Monday. So Monday, May 3rd, starting at 7 o'clock. And we're going to be talking about journaling. And we have some young cancer survivors who journal, someone who's actually studying the journey of cancer and journaling for her PhD. We have somebody who has written and published a book of her experience with a family member who went through ovarian cancer. So I think it's going to be a great session, very exciting, a lot of fun, a little bit different than some of the sessions that we've done up to this point. And then 1 month later, on June 6th, is our race. So we have our 6th annual Stride and Thrive race, which is going to be virtual this year, which means it will all be online. You can do it from the comfort of your home. You can still race. You can still have a team. You can still do all the awareness and loudness, enthusiastic, drawing attention to GYN cancers that everybody does each year, just in a slightly different format. And on that, on the day of the race, we will have some virtual content, including hopefully getting some of my colleagues to do some sessions on the myths of GYN oncology, things that people are told that we want everybody to know are not true. So, as well as a lot of our survivors doing some talking about their own journeys and experiences. So I think it's going to be a great day and a lot of fun, similar but different from last year. So if you attended last year, all the things that worked well, we're going to keep, and we're going to expand to get everybody involved. So we hope to see everybody on May 3rd and hope to see everybody on June 6th at our race. And thank you again to Dr. Beavis and Mary Eve. I'm very, very grateful. And as always, it's fun hanging out with the two of you. So thank you. Good night, everybody.